Thank you very much, Mr. Chairman, and good afternoon, everybody. I've been very pleased to run this lecture because finally we have a chance to move away from radical prostatectomy when we discuss about ED after pelvic surgery. And in fact, if we look what else we have around, it's not only prostate, because we have also, as urologists, the radical cystectomy and the lymphadenectomy for testicular cancer. And then the general surgeon play a lot with colorectal pelvic surgery. And again, as urologists, the urethral reconstructive surgery and sometimes also BPH endoscopic treatment. So let's have a look about a little bit of numbers. First of all, of course, if we look at the numbers, the prevalence of prostate cancer is, of course, the first tumor in men. And so, as you can see, the percentage and the prevalence is quite high in these people, 40 to 80%, but it looks very similar also for radical cystectomy and the colorectal surgery. But if you look at this very interesting prospective study in people basically assessing the erectile dysfunction in men after pelvic surgery, in this pilot study, they found that colorectal colectomy was the most common reason of erectile dysfunction after pelvic surgery. And these are the numbers coming from the US Cancer Statistics National Inpatient Sample, and you can see that prostatectomy, of course, is the overall most important with 90,000 procedures per year, but it's not very much less if you put together the rectal resection, the radical cystectomy, and the TURP, that is the standard treatment for BPH. But the problem is that if you look about numbers in terms of publication, this is very poor in terms of compare between radical prostatectomy, ED after radical prostatectomy. We got something like 1,800 papers compared to 500 for all the other techniques. So this means that there is a lot of attention for erectile dysfunction in people after radical prostatectomy. It is very low for all the others procedure. And the pathogenesis is very clear. We know very well that we look after the neurovascular bundle and all the neurogenic component that can cause the damage coming from the increase of collagen synthesis and the smooth muscle cells reduction. And so these, of course, end up with a reduced compliance of the corporal cavernosa. But there is also an important impact of some kind of psychological and somatic factors in men. If you look now in the colorectal cancer, there are 4 main places where there is a high risk of neuronal damage. And of course, first of all, the hypogastric plexus, usually during the ligation of the inferior mesenteric artery, and then the pelvic plexus, and there is a few places where this can be injury. And finally, we look after the cavernous nerves, especially during the anterior mobilization of the rectum, whether we got more problem with the pelvis splanchnic or erygentus nerves when we go on the posterior rectum mobilization. And again, it is very important to take attention about this other important information with regard to colorectal cancer. First of all, there is a high prevalence of erectile dysfunction in the first year. And if you look in the other paper that is on these slides, you can see that with difference of erectile dysfunction after radical prostatectomy, there is not very much increase after 1 year of treatment. So this means that the patient mainly are already with a, let's say, bad condition in terms of erectile function before surgery. And so there is no better kind of improvement when they do any kind of treatment after surgery. And it's a little bit different, the condition of radical cystectomy. There is some numbers that are quite probably not expected. First of all, the erectile dysfunction is common, but often overlook complication after the procedure. We know that if we look about the questionnaire that we use for sexual function, they are very similar without any respect of the procedure that we do. And this is a little bit surprising for me because it's quite different when you do a continent new bladder rather than do a ureterocutaneous stomy. And, but this doesn't make big changes. And also, there are a lot of different reasons why they can have erectile dysfunction due to a combination of iatrogenic, organic, and psychological factors. Different condition if we look about the retroperitoneal lymphadenectomy, mainly for, of course, the testicular cancer. Here, the main problem is the dry ejaculation. But there is numbers, there is this publication on 400 survivors when they see that there is also a problem of erectile dysfunction that is usually most associated to the problem of the dry ejaculation. So again, this is a problem, although the main one is with regard to ejaculation. And if you look about the procedure about the urethra, when we treat this is a little bit, let's say, discussed topic because there is a thought that these people have a decrease, some kind of decrease of erectile dysfunction. But if we look about the anterior urethroplasty, usually this patient have a resolution of the condition in the first year after the procedure, whether the posterior one, it's more complicated patients, and so the rate of AD is much higher, and sometimes they may have an improvement when the treatment of urethra is done completely well. If you look about the de novo cases, this is a very interesting systematic review and meta-analysis looking about 36 studies, over 2,300 people, and as you can see, the incidence of ED is pretty low. It's 1%, and usually 86, or the majority, resolve in the first year after treatment. And if we look about the most, let's say, important cases, that is the people that have a urethral injury after pelvic fracture. So this patient is completely different condition because they may have a more important erectile dysfunction, is usually percentage around 50% of them, and usually the rehabilitation is not only the medical treatment, but sometimes there is also, in some selected cases, the possibility to do a reanastomosis or rearterialization in order to provide any blood supply if this has been injury after pelvic trauma. And lastly, the BPH surgery. Again, if you look about over 150 studies, over 20,000 patients, again, the major problem here is the retrograde ejaculation, but there is a percentage of people also reporting erectile dysfunction. And so I believe that it's very important after pelvic surgery that we do an early assessment of patient, and we have to try to define who have a normal erectile function status and discuss the possible treatment goals. The early treatment is always much better in terms of outcome and long-term potency. The issue are that the lack of agreement of compliance with regard to protocols and the scarce assessment and counseling of these people before surgery in terms of erectile dysfunction. So I do believe that anatomy is, of course, the key when we do this surgery, although nowadays that we use robotics, so we are much more precise. We didn't have such a big increase in terms of no erectile dysfunction. But sexual dysfunction is often overlooked and not completely discussed before procedure, and especially when it's not the prostate, the organ that we need to operate on. So all patients must undergo a very good assessment preoperatively and counseling, and also a good post-op rehabilitation. So it's not just prostate cancer, but it's all pelvic patients that matter and we need to look after. Thank you very much.